Good evening, everybody. My name is Dr. Chioma Izimbiaya, and I'm a clinical academic in Imperial College London and a consultant endocrinologist at Imperial College Healthcare NHS Trust. Thank you so much for joining us for our webinar today, where we'll be discussing advances in precision management of metabolic conditions, where we have the privilege of being joined by three excellent clinician scientists who are going to share some of their work with us today. And so just before I introduce our first panelist, just a little bit of housekeeping. I'll be very grateful if you could put all of your questions in the Q&A and not in the chat. So please put your questions in the Q&A. We will answer all of the questions at the end after all the speakers have had the chance to present their work. And just in case you get distracted or you can't stay for the whole seminar, this is being recorded and it'll be available on the AOP YouTube channel later on. Okay, so without further ado, I'm going to introduce the first speaker, but as a background, today is indeed World Obesity Day, so it's a good day to have this webinar. Obesity and indeed type 2 diabetes continue to increase in incidence and prevalence all around the world. Encouragingly, there are many new treatment strategies to try to address the management of these conditions, but we know there's quite a variation in response to the efficacy of these treatments in different patient groups. Therefore, precision management in obesity and in type 2 diabetes is going to become increasingly important, and there are several ways that we might hope to achieve this. I'm going to first of all introduce Dr. Shivani Mishra. She is currently the recipient of a Wellcome Trust Career Development Fellowship. She's a senior clinical lecturer at Imperial College London and an honorary clinical diabetologist at Imperial College Healthcare NHS Trust, also in London. She has a portfolio of research studies investigating the genetics, epidemiology, classification, and management of early onset type 2 diabetes. In addition, she also has another set of studies which seek to advance our understanding of precision medicine in type 2 diabetes. She's recently been honored with a wide variety of awards from societies specifically looking at the research of diabetes, as well as NHS England. And for her clinical work, which stems from her research, the NHS has recently rolled out the T Today program, which seeks to improve the management of people with young onset type 2 diabetes. And so now I'll hand over to Dr. Shivani Mishra.
Thank you, Chioma. That's such a lovely introduction. And hi, everyone, and welcome to this webinar. And I'm going to jump straight in and talk to you about precision medicine in type 2 diabetes, which, as Chioma mentioned, has become a bit of a side gig for me. Now, let's jump right in and define what we mean by precision. And you may not have seen the consensus statement that some of us were involved in publishing last year in Nature Medicine. It's a long read, but worth it. And basically, as you might expect, precision medicine emphasizes tailoring of diagnostics or therapeutics to subgroups of populations sharing similar characteristics. And sometimes precision medicine and personalized medicine are used interchangeably. So we've defined precision medicine. What does type 2 diabetes mean? And this is a little bit of a flippant question, because I want to share with you some people that I recently saw in my type 2 diabetes clinic. The first one is Yang Mi, who's of Chinese heritage. She's had diabetes since she was 25. She has a BMI of 22, and you can see the HbA1c there is not quite at target. So she's lean, but has type 2. And then Jonas, who was from East Africa, and he presented with this sort of ketosis-prone type 2 diabetes phenotype, slightly overweight with a BMI of 26 and in DKA at diagnosis, but now off all treatment. And I'm seeing more people like Kirti. Kirti's young, but she has type 2 diabetes. And as Chioma mentioned, this is a focus for me in my Wellcome research. She's living with obesity and she has suboptimal glucose control as well, and already has evidence of complications. And then we've got Mark, and Mark is really the sort of person that I learned about when I was at medical school. He's a bit older, he has a BMI of 35, responding reasonably well to GLP-1. Now, how is it that all of these people are labeled with type 2 diabetes? And actually, we don't call them all type 2 diabetes. We prefix them with things that qualify. So Yang Mi's got lean type 2, Jonas is ketosis prone type 2, Kirti is early onset type 2. And then Mark, I like to say, is sort of garden variety type 2, which is what we all learnt about. So clearly, type 2 diabetes is a very broad label that encompasses a lot of different subphenotypes. And arguably, we should not be treating Yang Mi, Jonas, Kirti, and Mark in the same way. So what do these specific phenotypes tell us? Well, they tell us three things. One is that the etiopathogenesis of type 2 diabetes is heterogeneous across and within ancestries. It's not the case that everybody of Chinese or Indian or African heritage is going to present like the vignettes I just showed you, but those subphenotypes tend to occur more frequently in other ancestry groups. It also tells us that the lifestyle or the environmental component of risk is likely to be unmasking differential genetic contributors. How is it that Yang Mi and Kirti in the previous slide both have type 2 diabetes, but one has a BMI of 22 and the other has a BMI of 27? Clearly, there must be underlying genetic contributors. But it also tells us a third thing, and that is that, as I believe, our guidelines are currently inadequate because they tell us pretty much that one size fits all. And I can't tell you the number of people I've seen like Yang Mi who have lean type 2. And I'm not going to go into it in this talk, but let's assume we've excluded type 1 diabetes. Let's assume that we've excluded monogenic diabetes and we're left with lean type 2. And lots of healthcare professionals will tell Yang Mi that she needs to lose weight. And I think that's the wrong advice for somebody that has lean type 2 diabetes, because intrinsically they must have a problem producing insulin. So what do we do when we see a new presentation of hyperglycemia? Well, I'm not saying we're particularly good at it, but we're definitely getting better at identifying monogenic diabetes in that ocean of type 2 diabetes. And there might be some red flags for type 1 diabetes as well, or other types, for example, pancreatic type 3C. And everyone else just gets lumped into this group labeled with type 2 diabetes. It's almost a diagnosis of exclusion, or rather, more often, the default diagnosis. And I still think it's incredible that despite all of the advances we've made, we actually don't have a test to conclusively tell someone that they have type 2. We have tests to rule in type 1 and monogenic, but we don't have anything to say you've got type 2 diabetes. And so we bung everyone into this bucket of type 2 diabetes, but as you've seen from those case vignettes, it's very heterogeneous. And we can start to segregate people in this group on the basis of certain clinical features, as I showed you in the previous vignettes. For example, age of onset, presence or absence of DKA, or the BMI. Is it lean? Is it overweight? Is it obese? But what we see is considerable clinical variability in the way people present, how they respond to pharmacotherapy, and the risk of progression to complications. So the question really arises, can we be more refined in our approach? Now, broadly speaking, the answer is yes. There are many, many groups working on this, including my own. And we can be reactive to classification. So as I've shown you, we can look at the clinical phenotype and say, well, that person's obese, that person's lean, that person needs insulin, that person doesn't need insulin, that person was in DKA, that person wasn't. So this is a very reactive classification-based system. Or, as many people are trying to do now, we can really dig a bit deeper and look at the etiopathogenesis, and that might be incorporating genetic markers, or it might be combining multiple biomarkers to really understand the underlying pathophysiology. And we're starting to see that with some of the approaches that can identify people with lipodystrophic type phenotypes versus beta cell dominant type phenotypes. And if you're interested, because we don't have time in today's presentation, but if you're interested, please have a look at our systematic review of all of the different approaches to classification. And what you can see is that what's predominating these days in the literature are computational approaches towards classification. And that's shown in the cartoon on the right-hand side. So you can input different variables, for example, the BMI, the HOMA, the HbA1c, or even more complex omics data. And you can undertake different machine learning methodologies to subtype type 2 diabetes. So what would state-of-the-art precision medicine look like? Well, I've taken, I hope Professor O'Reilly doesn't mind, but I've imagined that I'm sitting in clinic with him and he calls in his next patient, and his next patient is me, with newly diagnosed with diabetes. So how could we advance on what's going on at the moment? Well, he might take a finger prick and undertake some precision blood tests in inverted commas. And he might say to me, well, Shivani, you've got type 2 diabetes subtype 623.4b, and you need the following treatment combination. And I've measured your serum rhubarb level, and I advise starting an ACE inhibitor because you're at risk of renal failure in the future, and we need to protect you from that, etc., etc. So this might be, I'm not saying this is my vision of what precision medicine would look like, but this is what we're effectively heading towards, a more nuanced diagnosis and a more nuanced treatment. So how much of a reality is this today? Well, let's just run through the steps that we need to be able to achieve something like this scenario that I just mentioned. First of all, we need to precisely subclassify type 2 diabetes. We then need that to be a useful subclassification. There's no point me saying, oh yes, you have a high chromogranin A and you have a low chromogranin A. What does that actually mean? Does it associate with a difference in complications? So we need to have a useful classification. Then we need to leverage those classification differences to select a more targeted treatment and a precise prognostication. And then we need to show that that prognostication improves outcomes. And finally, and this is the most important thing, we need to make this clinically usable, because we can come up with the most precise subclassification and manageable. If it's not being used at the interface by, for example, GPs who see the majority of people with type 2, then it's not going to make a difference. So where are we with evidence that stratification works? Well, again, just a précis given the short time today, but the field is moving very, very quickly. On the left-hand side here, you can see the first ever randomized controlled trial of a precision medicine approach that stratified patients according to their BMI in the top panel and their eGFR in the bottom panel. And it shows marked differences in the glycemic response to sitagliptin on the left and favors pioglitazone on the top right or canagliflozin on the bottom right. Don't spend too much time looking at this. Just note that there are significant differences in drug treatment response on the basis of simple routine biomarkers. And here's a very famous graph taken from a study by Emma Alkvist in 2018, which shows the first clustering study. And what it shows is that if you cluster on the basis of simple routine features at baseline, you progress differently. And this graph shows the progression to end-stage renal failure. And the green line, which obviously progresses quite rapidly, is the SIRD, or the severe insulin resistant group. So even at diagnosis, you can predict who's going to develop these complications. Now, this clustering approach has really taken hold. This is in our systematic review. It shows huge number of studies, now all looking at the clustering methodologies. I'm not going to go through it, but I will say that it does have limitations. These clusterings assignments can change with time. And really, again, as it boils down to, will this be used and can it be applied in all ancestries? So just in the last minute or so, I think where we're at in this pathway of precision medicine is that we've got to an approach where we can subclassify type 2 diabetes in a more refined way, but we're yet to be able to leverage that treatment, stratification using more targeted treatment. But this, just to whet your appetite, came out just last week in Diabetologia from the Exeter group. Again, a very complicated graph, but all I want to show you is that the brown represents the response to an SGLT2 inhibitor, so how much your HbA1c reduces, and the darker the color, the greater the HbA1c reduction. And the blue is the same for a GLP-1. And the key point here is that these are all not at the same level. And you can see that things, very simple things like age, HbA1c, EGFR, and even gender will influence the degree to which you achieve glycemic reduction on these agents. Now, of course, 4 out of 5 people living with type 2 are in low and middle income countries. So we need to make sure that whatever we do in this space has the ability to reach all of the people with equity and equality. So that was a run through, very fast run through. What have we covered? Hopefully I've shown you that the type 2 diabetes label inadequately covers disease heterogeneity, and a more refined classification based on clinical features is needed. And this is especially true across diverse ancestries who are underrepresented in most T2D studies. There's lots of different approaches to stratification. Clustering has definitely taken hold. It's associated with mortality, CVD, and renal outcomes. And there's some way to go to make clinically usable tools from these stratification methodologies, and to also prove that they are superior and cost effective versus standard care. And actually, maybe someone will ask me this, is it worth delivering this? Maybe we should just put everyone on a GLP-1 agonist. I'll wait for that question. And so I just want to finish with this quote from William Osler, who said in 1892 that it is more important to know what kind of a patient the disease has than to know what kind of a disease the patient has. And I think he was quite prescient about the concept of precision medicine in making that quote. Thank you very much. Back to you, Chioma.
Well, Dr. Misra, thank you so much. That was an excellent talk and a lot of food for thought there. Right, so while Dr. Ben Jones gets ready to share his slides, it's my pleasure to introduce him. He's currently the recipient of an MRC Clinician Scientist Fellowship. He's a clinical senior lecturer at Imperial College London, and he's a consultant in metabolic medicine at Imperial College Healthcare NHS Trust, also in London. So primarily his research is focused on translational pharmacology of the G protein coupled receptors, especially in the space of metabolic disease. He has made significant contributions to our understanding of the concept of biased agonism, especially when it comes to incretin receptors. Indeed, we're all familiar with the expanded use of GLP-1 receptor agonists in clinical care. And so I think with this field is going to become even more exciting, especially as it may be used to inform the rational design of medications. Right, so I'll hand over now to Dr. Ben Jones.
Thank you very much, Dr. Izzy. Sorry for the delay. Let me just get my laser pointer. Can you all see that okay? Yeah. Okay, so I'm going to move to the opposite end of the spectrum and talk about receptor pharmacology, specifically a concept known as G protein biased agonism, and how this might be applied at the GLP-1 receptor, which, as I'm sure you all know, is an important target in type 2 diabetes and obesity. So here's my disclosure slide. So my lab is interested in understanding the factors which can influence G protein coupled receptor or GPCR signaling, and the consequences that this can have in type 2 diabetes and obesity. And I'm going to focus particularly on this topic here, biased agonism, but I'm also interested in the impact of missense variants in the target receptors that we study, and other things like the local membrane environment in which these receptors are sitting. And we use a variety of different in vitro and in vivo approaches to measure these differences, with the aspiration to try and translate these findings into humans in the future. So just a little bit of undergraduate pharmacology. Many of you will recall that agonists can be divided into either full agonists or partial agonists. And a partial agonist, even if you give a high dose, will only reach a sort of submaximal response, as shown here. But actually, of course, these receptors are coupled to a variety of different intracellular proteins. So we have, for example, the G proteins, as shown here. They are primarily responsible for intracellular signaling. And then we also have the beta arrestins, which have a number of roles, but one of those is to switch the receptor off, desensitize it, maybe produce tachyphylaxis. And that's really important physiologically. We need to have ways of switching off hormone and neurotransmitter signaling for physiology. But for a drug, that might not be ideal because you want your drug to have a long-lasting effect. So we've been quite interested in the idea of G protein biased agonism. So in this situation, we have specifically designed ligands which activate the same receptor. They still produce G protein dependent signaling, but they can avoid beta arrestin mediated desensitization. And so the idea here would be that we can promote longer term signaling by avoiding these switch off mechanisms. I'm just going to move. I'm not sure if this thing on the side is in front of the screen, but hopefully you can see my entire slides. Anyway, I don't seem to be able to move it. Okay, so that's an interesting pharmacological concept. Why might it be relevant therapeutically in the context of diabetes and obesity? Well, you'll be aware that there's a number of GLP-1 receptor agonists available on the market. Liraglutide, dulaglutide, semaglutide, and a new one, danuglipron, which is currently in phase 3. It's an oral GLP-1. It's quite an interesting one. These are all considered as balanced GLP-1 receptor agonists, so they're not biased. But what we also have are some new molecules, for example, tirzepatide. This is actually a GLP-1 GIP receptor co-agonist, so it hits two receptors. But at the GLP-1 receptor, it has quite pronounced bias in favor of the G protein pathway, and now approved for type 2 diabetes and under consideration for obesity at present. Another example currently in phase 3, orforglipron. Again, this is an oral GLP-1. It's not a peptide, so sort of like a small molecule, although not quite. And again, this has got really quite strong bias in favor of G protein signaling. So I think it's very difficult to directly compare these kind of ligands, but I think overall the data suggests that these ones might be a bit better than these ones. Now, the problem is we don't know if that's due to the biased signaling, which they clearly do show, or whether it's something else. Obviously, tirzepatide as a co-agonist acting at a second receptor, that's clearly a potential reason why it may be better than a monoagonist such as semaglutide. Or it could be the bias, which would be sort of interesting for me. And the problem is, because these molecules have all got different stabilities, different pharmacokinetic profiles, different dosing regimens, you can't directly compare them on the basis of the available clinical data, at least if you want to infer mechanisms. So that's something that we've been working on for a little while now. So one of our aims has been to develop oppositely biased GLP-1 receptor agonist molecules, which have got equivalent stability and equivalent pharmacokinetics as well. So we take those differences out of the equation, and so we can just look at any sort of functional consequences which could be attributed to this biased signaling. And then we sort of test these in cell models, in preclinical in vivo models, disease models, and then eventually we wish to do studies in humans as well. So to give you an example of a pair of good examples here. These are a couple of tool compounds that we've been working with for a while now. They are peptides. They're heavily based on exendin 4 or exenatide Byetta, so you may know it, existing type 2 diabetes drug. And the only difference is that they have amino acid substitutions at or close to the N-terminus, as highlighted with the sort of colored circle there. And yeah, because they're so similar in all other ways, they have the same stability, the same pharmacokinetic profiles. And so we think that we can use these to tease out any effects, downstream effects that they have, which it might be attributable to bias. And as an example, so this is a sort of an in vitro signaling assay. On the left, we have a dose response looking at G protein signaling, cyclic AMP. And on the right, we have beta-arrestin recruitment. You can see that both ligands have the same maximum response for the G protein pathway, but for the beta-arrestin response, then the F1 ligand basically just does nothing. So some people might refer to this as a perfect degree of bias between G protein and beta-arrestin signaling. I think it's worth just flagging that there is also a difference in the G protein pathway, which is that the F1 drug has reduced signaling potency. So in vitro, you need to give higher doses to get the same effect from this sort of left-right shift here. But anyway, so what might be the impact of this different pharmacological profile? So showing this image again, then because the arrestin, one of their primary roles is to switch the receptor off, by avoiding that response, then we might anticipate that the F1 drug would produce longer lasting signaling effects by avoiding desensitization, tachyphylaxis. And indeed, this is what we see in vivo experiments in mice. So here, what we have is mice which have been treated with these biased agonists or derivatives thereof, or a control. And what we can see is that over time, after a single injection, the mice which have received the F1 drug can eat less. And that tends to diverge after about sort of 12 hours plus. And then when we extend this over a longer treatment period, 2 weeks, then we see that line continues to diverge, and this leads to greater weight loss. And this, I think, is quite interesting because, as I showed on the previous slide, this biased agonist drug has actually got quite low signaling potency. So, you know, it's something that probably would have been discarded in a traditional drug discovery program because it has low signaling potency. But actually, it works very well in a physiological system. So the question is, does this matter in humans? Well, the answer is we don't know yet. There is quite an interesting paper from Ewan Pearson's group, which analyzed the impact of mutations, loss of function mutations in the beta-arrestin 1 gene. And in the context of GLP-1 receptor agonist trials, these mutations, shown in blue, led to a greater response to these drugs in terms of the ability to lower blood glucose. So I think there are some clues there. We do need larger scale pharmacogenomic data to clarify the role of beta-arrestins, the role of bias signaling in the therapeutic response to GLP-1. And I think we also need to be doing a sort of direct physiological comparison of the kind of ligands that I showed on the previous slide, where we know that they have the same pharmacokinetics, and we can compare how they act physiologically in humans. And then the final point I wanted to make is that, well, you may well be aware that there's quite a lot of missense coding variation in all genes. And certainly for the GLP-1 receptor, around 2/3 of people have at least one missense coding variant. Probably most of those are fairly benign, but there are some which are potentially more impactful. And we were interested to know whether this might, the functional impact of these kind of variants might have ligand-specific effects. So will they differentially impact the ability of the receptor to respond to different drugs? And so, without going into the detail, the bottom line was that when we compared 3 sort of clinically relevant GLP-1 receptor agonists, exenatide, semaglutide, and tirzepatide, then, for example, this variant here, which is an important one physiologically, showed quite a marked discrepancy in terms of its ability to respond to tirzepatide versus exenatide. And of interest to me, tirzepatide is a biased agonist. So yeah, it may be that this applies beyond tirzepatide and could apply to other biased agonist ligands as well. So just to finish up, in my opinion, biased agonism is a potential route to improving the therapeutic targeting of G protein coupled receptors, including potentially the GLP-1 receptor. Tirzepatide is a good example of a G protein biased GLP-1. We don't know if its beneficial effects are due to the biased signaling or whether it's primarily due to the effects of its GIP receptor activating component. And these kind of questions still need to be addressed in a proper human study. And then finally, so there's a lot of variation in these kind of GPCRs. The pharmacogenomic impacts of that are not currently known. And I think that will hopefully come out at some point in the future through large-scale pharmacogenomic data from the trials which are ongoing. And here are the number of people who've contributed to this work. Thank you very much.
Thank you very much, Dr. Jones, for that enlightening talk. And I'm sure it's made people think of lots of questions. So please put your questions in the Q&A box so we can answer them after the next talk, which will be given by Professor Sir Stephen O'Rahilly, who is the head of department and professor of clinical biochemistry and medicine at the University of Cambridge. He's also an honorary consultant physician at Addenbrooke's Hospital. He's a co-director of the Institute of Metabolic Science and is a principal investigator on an MRC program grant investigating molecular and pathophysiological mechanisms in obesity, as well as a Wellcome Trust program grant investigating mechanisms of human insulin resistance. He obviously has been the recipient of many awards from many learned societies, but most recently in 2023, the Association of Physicians awarded him the medal for outstanding contribution to translational medicine. So we're really looking forward to hearing your talk, Professor Sir O'Rahilly, and I'll hand over to you now.
Thank you. It's a great pleasure to be here. This is a picture of the Institute of Metabolic Science where I work, and there we kind of do we ask 2 questions. One is, why are some people fat and some people not? And the second question is, when you get obese, why do you get sick? And we try and use a wide range of technologies to address those problems and hopefully use that information to improve strategies for both prevention and treatment of metabolic disease. Now, I've used human genetics a lot in my work, and it's not unreasonable to ask, why bother? Why should we bother using human genetics? What's the point? It's a good question for any scientist to ask. And we generally bother to do things because they're either useful or they're interesting. And how might human genetics be useful? Well, people generally like having a diagnosis. If you can give people a specific diagnosis, it's much better than just giving them a vague terminology for their disorder. If we can make a specific molecular diagnosis, we kind of get a better idea of what's going to happen in the long term for people, and we can get improved prognostication. The great dream when human genetic revolution started is we'd be able to screen people early in life, identify those at risk of developing disease, and by selectively changing their behaviors or informing them, we'd reduce their risks. But that's still a little bit of a pipe dream. But what we have seen some definite advances in is the field of pharmacogenomics, where we can identify genetic disorders that can lead to therapies being targeted, at least selectively, towards individuals' particular disease mechanisms. Of course, we do science also because it's interesting, and genetics has taught us a lot about human evolution and development. I think one important thing that we sometimes don't remember quite as much is that genetics has been very useful in teaching us about human physiology. If we find people with, even rare individuals with genetic disruption of key molecules in controlling homeostatic feedback loops in the body, that can really give us an immediate understanding of how those loops are controlled. And not only is that interesting, then it can become useful, because those positions, those control nodes in the human genome can very rapidly turn into very useful therapeutically modifiable targets for novel drug development. A key thing about genetics, for those of you who don't think about it very often, is why do we do it so much? Well, it's really extraordinarily useful because it informs us about the direction of causality of our research. Many times, if you're doing research and you find two things varying, you're never sure which direction it is influencing what. Whereas if you find a genetic variant, it is very, very unlikely to be caused by the phenotype that you're studying, and it's likely to be unidirectional. And that's what gives genetics its tremendous power. So if we put together a picture of the key organs concerned with the control of energy balance, insulin sensitivity, insulin secretion, glucose homeostasis, this is the picture that we would see. The gut-brain axis, the liver and the muscle as key insulin target tissues for glucose metabolism. The adipose tissue is a storage organ, and the pancreas clearly as the insulin-producing organ. And what I'm going to give you just this one slide to tell you broadly what genetics has really helped us learn over the last 20 years or 25 years or more. And in essence, it's as follows. When we're talking about obesity, a state of increased body fat mass, by far the dominant signal that we get from genetics is the brain. Obesity is largely a heritable neurobehavioral disorder with the variation between the resistant and the sensitive largely being based around genes expressed in the brain. And again, if I turn now to metabolic syndrome, insulin resistance, you might think that the targets that clear the most glucose, the liver and the muscle, might be the place where we'd find most of the action that determines who's insulin sensitive and who's not insulin sensitive. And rather remarkably, our only boring little tissue, fat, turns out to be hugely important in determining which individuals can cope with overnutrition and which individuals cannot cope with overnutrition. And then finally, when it comes to type 2 diabetes and actually developing a high blood glucose, the real determinant of who gets those high glucoses and who doesn't is how well your pancreatic beta cell has been set up from birth. It's really a very dominant signal when you're actually looking for type 2 diabetes as your readout. So depending on which part of the whole spectrum you're looking at, you get totally different answers as to what's causing or what's driving metabolic disease. We started our interest in obesity some 30 or more years ago, and at that point, there had not been a single human described with genetic defects causing obesity, and we were fortunate to be the first to do so. And we and others, and my colleagues who started with me way back there as students and postdocs, have remained working in Cambridge, and we a highly collaborative group and team, Sadaf Baruki, Giles Yeo, Tony Cull. And what we found were genes, when they were disrupted, very reliably increase human body weight, sometimes very severely. And those genes were, in some ways, to some people's surprise, they were not in fat tissue. They weren't in tissues burning off energy. They were all in the area of the brain, largely in the hypothalamus, or in a gene like leptin acting on the hypothalamus. So we were able to show that genetic basis of highly penetrant obesity was all based around genetic disorders of the hypothalamus. We didn't suffice just to stop there and just describe where the genes were. We actually did take our patients in to the clinical research facility and measure whether they burnt off calories slowly or they ate more. And rather remarkably, the evidence was much more strong that these were disorders of appetite. So these so-called metabolic disorder of obesity was really not a metabolic disorder at all. It was a primary neurobehavioral disorder. You can see this in this graph here, where we look at kids with leptin deficiency, matched controls here, kids with obesity due to totally inactive melanocortin 4 receptor mutations downstream of leptin or partially active. And this is remarkable. Here's a single molecule in the central nervous system, and depending on how much signaling deficit you have in it, you can predict how much people will eat when they sit down for an ad lib meal. So really these processes in our brain are intimately connected to really what is quite a sophisticated process, a decision about terminating a meal. And while some of these disorders are uncommon, melanocortin-4 receptors are not that uncommon. We recently did a birth cohort study, every kid born in Bristol in 1997. Sorry, in 1990. This is the remarkable ALSPEC study. And in that, we found that 1 in every 330 of those individuals had got a functionally impaired MC4R mutation. That means there's 200,000 carriers in the UK, 1 million in the US, more than 20 million worldwide. And on average, every one of those individuals on average went into adolescence 18 kilos heavier than they otherwise would have been. Here's a great example of precision medicine. It's rare, but it's beautiful and moving when you can be directly involved in it. And when we discovered children lacking in leptin, we're able to give back leptin to them. It was really a dramatic and totally revolutionary observation. These children, and now we can do it much quicker now than we did it then. We were very gentle with the recombinant leptin. Now we know it's very safe. And we can restore normal body weight within 6 months to a year in these children, some of whom are so enormous that they're almost wheelchair bound. And we learned a huge amount about leptin's physiology from replacing leptin. One of the nicer experiments we did with our colleagues in psychiatry, Paul Fletcher and Ed Bullmore, were these lovely experiments where we took some adolescents who had never seen leptin before and they volunteered to go in a functional MRI scan. And if you showed them pictures of things like cars or footballers, not much happened. But you showed pictures of food, and the areas of addiction and reward in the brain lit up like a beacon. Now, the remarkable thing is when you gave leptin back, you could totally restore the normal pattern in the brain just within days of way before they lost weight. So here's an extraordinary business of leptin, a hormone coming from your adipose tissue, powerfully influencing your higher brain centers concerned with decisions about eating and not eating. And similarly, now distal to the leptin receptor in the brain is the POMC system. And now we have agents that have a similar powerful effect on reducing body weight. Here's kids with POMC deficiency, work from Heiko Kruder in Germany and groups in Paris. And setmelanotide, this MC4R agonist, is now a approved NICE agent for children with the defects in POMC or PCSK1, which we described many years ago, or leptin receptor. And there's ongoing and quite exciting phase 2 studies going on in things like Alstrom and Bardet-Biedl and other hypothalamic craniopharyngiomas, etc., where this is looking at like a very promising treatment for these conditions. So I'm going to move, this is a very quick talk, so a lightning talk really in 10 minutes. So I'm going to move from the causes of obesity to the consequences now. And obesity is really caused when energy intake exceeds energy expenditure. And that's really, obesity is an expanded mass of triglycerides in adipocytes. That's all it is. Sometimes the word obesity, I think, makes people stop thinking. They just think they know what it is. But really all it is the expanded mass of triglyceride in adipocytes. Now, why is that associated with such bad stuff? It's associated with things I classify into 3. I think this is a useful way of thinking about it. There are kind of mechanical and gravitational effects where simply the weight and mass of the triglycerides are contributing to the disorders. But then there's cancers, which are associated, just these 3, several, and a whole range of metabolic diseases. So it's pretty obvious that the obesity itself directly results in these. But why is it associated with cancer or metabolic syndrome? Is it the expanded mass? Or is it somehow that's just a biomarker and it's chronically exceeding between energy intake and expenditure that somehow is directly causing these illnesses, with the obesity being simply an observable epiphenomenon in what's truly going on? And so there are kind of 2 ways of thinking about how you might get from this sustained energy balance. Let's say when it comes to insulin resistance, because these are the 2 key tissues for glucose handling, your liver and your muscle. So how do you get from there to there? If you ask 100 diabetologists these days, you'd probably, because they go to regular meetings, they've been listening to talks at meetings, and they'll have been told that the big bad fat cell is the culprit, that it stuffs full of fat, it gets damaged, it starts having macrophages, they produce adipocytokines, And it's these bad guys that are causing the problem in the insulin target tissues. The only problem there is that's true in mice and beautifully demonstrable in mice, but actually it's hardly supported by a single jot of data in humans. Neither human genetics nor human pharmacology support this idea very much. And whereas 20 years ago, every pharmaceutical company was trying to develop anti-TNF, anti-IL-6, anti-RBP4 to try and block insulin resistance, they all found that those strategies never worked. It didn't do a thing. I think that's because a different phenomenon is what's really going on. And it's that actually your big fat cell is not your enemy. Your big fat cell is your friend. Because the worst situation is when you can no longer take triglyceride and energy into your professional energy store, and then you redirect it to non-professional tissues. And it's the redirection of energy and nutrients and lipid to those non-professional amateur tissues, liver, muscle, endothelium, heart, where you really start running into trouble. And we've learned this really from both monogenic and polygenic studies. David Savage, my great long-term colleague, and I have discovered many of the genes that cause lipodystrophy. Lipodystrophy is a condition not of thinness. It's a condition when you cannot make enough fat cells, or you cannot make fat in fat cells. And it's either total, as in the patient on the left, or partial, as in this patient in the middle. And these people develop all the complications of obesity in the absence of excess stored triglyceride. There is not one feature of obesity that these people, or at least not one that isn't the mechanical and gravitational, but all the metabolic and the cancer risks, etc., are all the same in individuals with lipodystrophy. So years ago, I think this is one of the most important papers we've ever been involved with our colleagues in genetic epidemiology. We asked a simple question. We said, if we take metabolic syndrome as defined by high insulin, high triglycerides, low HDL, and we simply ask the genome in a totally hypothesis-free way, where are the genes in which genetic variants predispose to that cluster of insulin-resistant abnormalities? And we were shocked and excited, but shocked to see that the only tissue that came out was the adipocyte, and the only tissues was fat. So genetic variation that made people either sensitive or insensitive to metabolic syndrome was a very strongly adipose tissue dominated signal. And indeed, when you take that genetic signal, you take a polygenic risk score for metabolic syndrome, and you start bringing it into other data sets, like the data sets of people who have had 12,000 people with DEXAs, you start seeing remarkable data. If you have a score that gives you a high risk of metabolic syndrome, it's not so much that you have a lot of visceral fat. By far the most striking thing is that you have less fat on your hips and thighs. And so this absence of functional and absence of safe fat is just like a form fruste of lipodystrophy, is a common underpinning of the metabolic syndrome across populations. And so that led me to, this is the final slide, the one that I often use in public talks, and sort of puts everything together into the soggy bathroom floor model of metabolic disease. Let's, think about the fact you go into a cheap hotel, the bathroom is there, someone's left the plug out, someone's left the tap on, but the bathroom floor is fine because you get a store, you get a pressure, you get a continuous throughput, and everything's fine. Now, we normally think about metabolic disease as we are obese and we increase energy intake too much, and maybe we close up the tap and have decreased energy expenditure. And so we fill up the bath and then we get nasty, soggy bathroom floor. And that's the ectopic lipid and muscle that's causing the insulin resistance. You get compensatory hyperinsulinemia. Together, these lead to all the features of the metabolic syndrome. And then once we stop having the compensatory hyperinsulinemia with vulnerable beta cells, when that finally give up, then we get hyperglycemia. But what we forget is that not everybody has the same size bath. And I think our work has shown that this adipose tissue storage capacity is really a very important variable that's different between individuals on the basis of genetics, possibly of prenatal nutritional state. It's a place where you can integrate a lot of the insults that lead to the risks of developing later metabolic syndrome. I find this a useful model even in thinking about how we treat diabetes. And rather depressingly, we really treat it at the very end of its life with our drugs that increase insulin secretion and include GLP-1 part of GLP-1 actions in that really are very late treatments in this cycle. We don't really have any drugs that are insulin sensitizers of that we think that metformin and SGLT2 are, but they're really not. What they're doing is actually reducing the compensatory hyperinsulinemia by putting glucose into different places, SGLT2 into your urine, metformin into your gut and lining, and reducing the compensatory hyperinsulinemia and therefore taking stress off the beta cell and reducing some of the other risk factors. Physical activity does indeed improve insulin resistance in skeletal muscle. It's an important part of the therapy of diabetes. But of course, we've had the biggest advance through really going up to the top, and with our recent incretin-based therapeutics at last having access to the tap at the top of this particular problem. We can, of course, we do have access to agents that alter our adipose storage capacity, PPAR gamma agonists, thiazolidinediones. Unfortunately, they have some off-target effects which have limited their utility, but it's still, they prove the principle that if you can change the size of the bath, you can dramatically improve insulin sensitivity and reduce glucose levels. And there's huge activity going on both in our own lab and elsewhere in trying to improve the efficacies of these appetite suppressants, adipose tissue direct therapeutics, and ways of trying to get ectopic lipid out of muscle and liver. And I think the next few years you'll see a range of additional pharmaceutical agents coming that will help us target our therapies towards the particular abnormalities which are most dominant in some patients versus others. And I'll just finish by thanking, that's just it's a very old slide, lots and lots of people I had over the years, our funders, but particularly our patients and participants without whom we would not have had a research program over the last few decades. So thank you all for your attention.
Oh, thank you very much, Professor Healy, for that whistle-stop tour of 30 years worth of research. I'd like to thank all three of my fellow panelists, and I'd invite you to please turn on your camera. So this is time for questions to be answered. Currently, there are no questions in our Q&A box, and I'll encourage our audience to please use that. But as I was listening to those very excellent talk, I had a few thoughts. Let's start with Dr. Misra. Dr. Misra, I think you gave us a teaser, really. You said, is it worth it? Precision medicine in type 2 diabetes, is it worth it? We're getting increasingly efficacious agents in the GLP-1 category with other things on the horizon. So really, is it worth it?
Thanks, Chima. I mean, as with my clinical and research bias, of course, I think it's worth it because having access to fantastic agents like Ben was describing is, of course, wonderful. But as I showed with the case vignettes, those sorts of treatments, whether they're treatments that reduce weight or some other treatment, they're not appropriate for everyone. One size clearly does not fit all with type 2 diabetes. So we really need to identify multiple approaches, and we need good ways to stratify people. With my teaser statement, I think really what I'm getting at is this issue that concerns me greatly, which is that the 4 out of 5 people living with type 2 diabetes globally are in low and middle income countries who don't have a secure medication pipeline, let alone access to fancy stratification tools. And if anyone's interested in that, we wrote a piece about that in Lancet D&E recently. So I think whatever we do in the precision medicine space needs to deliver improvements with equity across all resource settings. And really, that's what I was trying to say really with that slightly flippant remark, because to those people living in resource restricted areas, there are probably greater priorities. But the corollary to that is that those individuals are also the greatest at risk of clinical errors. And so if we think of precision medicine as an approach that reduces errors, they also have a lot to gain.
Okay, thank you so much for enlightening us. Now, if I just go over to Dr. Jones. So you highlighted an example of how biased agonism could perhaps increase efficacy or help us choose more efficacious agents. But I guess with my clinician hat on, what about side effects? Could bias agonism have a role to play there?
Yeah, good question. So it's something which has often been discussed in the sort of biased agonism space. The idea that if you have more than one intracellular signaling pathway, maybe one is responsible for the beneficial effects and the other is responsible for the side effects. There is some evidence for that in other receptor systems, for example, opioid receptors, although I think that's a little controversial. For the GLP-1 receptor, I'm not so convinced that that's the case. Having said that, there is a caveat, which is that many of the biased agonists that we see, and in fact, there's a comment, I think, in the Q&A alluding to this, many of these are actually partial agonists. And there is a theoretical mechanism by which a partial agonist could show preferential signaling in certain tissues, for example, anorectic or emetic, so nausea-producing areas of the brain, and well, selectively reduced signaling in those kind of areas of the brain. So that could be therapeutically valuable as well, but not through the sort of mechanism which you might instantly think of if you start hearing about biased signaling.
Okay, thank you so much for that. And then I will take, well, this one is for you, Professor Morahili. So in the chat, someone has asked, if we can clarify how weight loss might be helpful in the management of metabolic disease. But I think I'll just want to extend that. Given what you presented about the difference in genetic susceptibility, especially where we store our fat and fat storage capabilities, how would we utilize that information when we're counseling, or advocating weight loss as part of the management strategy for obesity and/or type 2 diabetes?
So I saw that question in the Q&A, and it's an interesting one. I mean, there's no doubt that if you manage to lose weight, significant amounts of weight, you do take that lipid out of the non-professional tissues. You take it out of liver fat, and you do improve insulin sensitivity, and you can, for a period of time, even reverse hyperglycemia. And we know from the wonderful work of Mike Lean and Roy Taylor and the enthusiasts they are for this approach, there's been a feeling that maybe we could actually even get remission in type 2 diabetes. Now, the real world data on that, and there's been recent work from Hong Kong, etc., suggests that maybe that's a little optimistic that we can get that for a long time, and that yes, it's always beneficial. But the idea that the majority of people with type 2 diabetes, if they lost weight and kept it off, would be able to get on without medication, without any other something, is probably a little over optimistic in the real world. You got to remember that for many of these studies done by Roy and Mike, there's a subset of people where it was a subset of people who chose to, very small subset, who chose to go to these protocols. It's highly selective. And so, I mean, the answer is yes, it's fantastic if you get that response, and some people can get a persistent response, but not all do. I mean, clearly, one of the paradoxes of type 2 diabetes, or paradoxes of diabetes research, is insulin was the first hormone ever to be measured, and we almost never measure it in clinical practice, and it's kind of bizarre. But there we are. We like being a thyroidologist and not measuring TSH, but yet we do that all the time because insulin is quite hard to measure. It's a bit of a mess. It has to be frozen. It has to be. So it's pretty strange that we try and practice this sort of endocrinology without measuring the key hormone. And what would be really nice is to be able to see if even short-term dietary takes someone, see what happens to their insulin resistance within a very short period of time of diet. And if they get a very good response, that could predict that they were going to do really well. But we don't do that sort of thing in clinical practice, sadly. If someone, I mean, Shivana showed a case, which was very likely to be a lean woman with quite substantial insulinopenia, they are much less likely to do well on caloric restriction because you're dealing with a primary but partial pancreatic beta cell defect, and that's very unlikely to do very well with and as one of the things that happens is as diabetes starts going into primary care, and sometimes often not just to the doctor but to a practice nurse, and sometimes even a less than qualified person, they just follow protocols, and unless people understand the heterogeneity of diabetes, then some pretty awful stuff can go on, and people can be miserable for years being on inappropriate bits of an algorithm. And that's what we kind of, I think Shivana and I and Ben would want people to get a bit more thought being put into their personal therapy. You're muted.
Thank you so much. Classic error there. Thank you so much to Dr. Shivani Misra, Dr. Ben Jones, Professor Sir Stephen O'Reilly. Thank you so much to the Association of Physicians for hosting this webinar. And thank you so much to everybody who joined. I hope we've all learned a thing or two. I definitely have. And I hope that will help us to inform our research and our clinical practice as well. Thank you, everyone.